Assalamu alaikum, everyone. This is going to be the, excuse me, this is going to be the histology and the microbiology review for the OSPE for our final in HNS. Inshallah, it's going to be inclusive as everything that we discussed or like that we learned, and it's going to be like a brief review. Okay, so let's start, inshallah. So this is the first, these are the objectives. We're going to do the histology first, and then some questions or like OSPE questions about the histology. That should include everything. And then we're going to go to the microbiology part of our lab with the organisms, their lab tests, their diagnosis, shapes, etc. We're going to discuss the pathophysiology, obviously, because this is not a microbiology lecture, and also practice questions, obviously. So let's start. With the histology, we have the eye. We have the three main layers of the eye: the outer fibrous, the inner, or sorry, the middle vascular, and the inner neural. The outer fibrous layer is also called the corneoscleral layer of the eye because we have the sclera and the cornea in it, and these are the fibrous layers of the eye. The first layer is the sclera, which is the white part of the eye that we can see. The main function of this part is for structural support and for protection of the delicate eye structures. For histology-wise, the thickness of the sclera, it differs depending on the area or the direction we are in. So the anterior surface of the sclera is thinner compared to the posterior surface of the sclera, and this is seen here. Here we have less pink and less like white or like fibers, if you will, and here we have like a thickened layer of the scleral tissue. Okay, so why is that? It's for protection. The main function of the sclera is to protect the eye. Where are the delicate eye structures, like the retina, like the optic nerves and everything? This is in the posterior aspect of it, over the eyeball. So that's why the sclera is thicker in the posterior surface. So what is the tissue of the sclera made of? It is made out of collagen elastic fibers. Okay, collagen fibers, because for integrity and for strength and for elasticity as well. And whenever we have collagen, we also have fibroblasts. Okay, the other thing is of the sclera functionally is that it is pierced at area cerebrosa by vessels and nerves. Okay, so again, it is the opaque white part pierced by area cerebrosa by vessels and nerves, and it is made out of dense connective tissue layer, which is irregularly arranged. And this is also important in its function because when we have irregularly arranged fibers or dense connective tissue, that means that it is for structural integrity, and dense means strong, so like strength and support. Okay, so again, we discussed that the thickness varies. It is thin in the anterior and thick at the posterior. And this is another picture of the layers of the sclera. Out here, we have the bulbar conjunctiva, okay? And then bulbar conjunctiva, we have the episclera, and then the scleral stroma, and then we have the choroid inside. Okay, this is just an overview. Now we finished sclera. What we have as part of the fibrous layer of the eye is the cornea. Okay, so the cornea, it is made out of 5 layers, and each layer can have a sublayer, if you will. So the 5 layers are the epithelia or the corneal epithelium, and then you have the Bowman's membrane, and then between the epithelium and the then we have the stroma, and between the epithelial layer and the stromal layer is the Bowman's membrane, which is an acellular layer. And then we have the stroma, and then we have the endothelium. Between the stroma and the endothelium is a Descemet's membrane. So in total, we have 3 cellular layers, which is the epithelia, the stroma, and the endothelium, and 2 acellular membranes, which is the Bowman's membrane separating the epithelium from the stroma, and the Descemet's membrane separating the stroma from the endothelium. Okay, now let's talk about the epithelium or the corneal epithelium first. And as I mentioned earlier, that we have a total of 5 layers of the cornea, but the epithelia has 5 sub layers. Okay, so let's discuss them. The corneal epithelial layer, it is 5 layers of main cells, and these cells are connected by the chromosomes. That's not in the lecture. So anyways, the first layer or the superficial layer of the corneal epithelia is the squamous flat cell layer. It doesn't have organelles, but it is flat and it is thin. Okay. Uh, the organization of the cells, they are pycnotic, so they only have the nucleus, but they don't have the organelles. Okay, then we have the polygonal cell layers. The shape of these cells obviously are polygonal cells, and these are for structural support of the corneal epithelium. And then you have the basal cell layer, and basilar cells are basically like stem cells. They differentiate into these squamous cells. So we have the basilar cells here at the base, and then they ascend up as they mature and become and lose their organelles and become pycnotic and become the squamous superficial layer of the corneal epithelium. Okay, this is the same thing that I just mentioned, but in the in a histologic HNA stain. Here you have the squamous cell layer, which is a thin layer made out of the nuclei, pycnotic nuclei, and it's only thin and it is squamous. Then you have the polygonal cells, and you have the basilar layer, the basilar cell layer, and the cells themselves, the shape of them is either a low columnar, so it can be a low columnar. This is a low columnar, or it could be a cuboidal, which is a little bit, I think, like this, like a shorter. So it's either a low columnar or cuboidal cells. The functional significance of these basilar cells, as I said, it is for the differentiation into surface squamous cells. For that to happen, it should have a high regenerative ability. So if we have a question asking us which layer of the cornea has a regenerative ability, it is the corneal epithelium, because the rest of the layers, they are not regenerative, or like partially regenerative, but not as extensive as the corneal epithelium. So this is good because it protects us. For example, when we have eyelashes or when we have dust particles that act as an insult to the corneal epithelial layer and maybe injure it, we don't directly go into la qaddar Allah, the corneal opacity pathology, because this layer directly regenerates. Okay. Next, it is contained with the bulbar conjunctiva, because we have the conjunctiva like at the edges. Okay, now the next layer of the cornea is the Bowman's membrane. Again, Bowman's membrane is acellular, it is avascular, it doesn't have regenerative ability, and it is the line between the epithelia, the corneal epithelia that we just discussed, and the corneal stroma, which we are going to discuss in the next slide. Okay, so three things. It is acellular, it is avascular, and it does not regenerate. So yeah, if we have injury to the Bowman's membrane, it could lead to corneal opacity. And the reason behind that is because of the recurrent corneal erosion. So a corneal erosion, like if a lash came into the cornea, nothing will happen, epithelium will regenerate. But if you have like constant recurrent case of it, it will affect the epithelia, go into the moments you have, قدر الله, بس يعني you get the corneal opacity. Okay. Next is the corneal stroma. Corneal stroma is the thickest layer of the cornea, and it is made out of collagen fibers and elastic fibers. The significance here is that arrangement of these fibers. So we have collagen fibers everywhere, but not everything is as clear as the cornea. We know that the cornea is the clear surface of the, or like the clear glass before the iris, as Dr. Salwa rightfully mentioned. The cornea, what makes it transparent is the arrangement of the fibers in its stroma. So the fibers are arranged in a parallel fashion. Let me go here. So it is arranged in a parallel fashion. So when light comes, it doesn't get impeded by, for example, a cell that is lying randomly in anywhere. So light comes in, it doesn't get impeded because the structures are highly organized in a parallel fashion or an orthogonal fashion. It contributes to the transparency of the cornea. So if you have damage to the corneal stroma, or like the fibers are not arranged in this highly organized manner, what will happen is that the transparency ability, the transparent characteristic of the cornea is not there. You have corneal opacity again. So yeah, I just said that it has limited capacity for regeneration and self-repair, and that's why when it gets injured, we have what we call the corneal transplant. Okay, now here in the stroma itself, you can see these black, not black, like pycnotic nuclei, and these are basically fibroblasts, because whenever we have collagen, obviously I have fibroblasts because these are the cells that produces the collagen. Okay, you're done from the stroma. Now for the other layer, which is the Descemet's membrane. This is the fourth layer of the cornea, and it lies again between the corneal stroma and the endothelial layer, which is the innermost layer, and it is the second membrane, so it is also acellular. The only difference between the Descemet's membrane and the Bowman's membrane other than the fact, obviously, that they are in different locations, is that the desmoid membrane has an ability to regenerate, but the Bowman's membrane does not. Okay, so this is the difference between the two. And again, it's a membrane, so it is like a barrier. It's for also protection. And that's it. It lies between the stroma. This is a stroma, and here is the endothelium, which we're going to discuss right now. So the corneal endothelium, which is the innermost layer of the cornea before we get into the posterior chamber and then the iris, is a single layer of a simple squamous cells that are very metabolically active to regulate the fluids that comes in, because you know that the cornea is transparent, and it is also avascular because blood vessels are red. I always think about it this way: blood vessels are red. We don't want the cornea, which should be transparent, to appear red. So we don't have blood vessels there. That's why the cornea is avascular. But it is an active structure that obviously needs its blood supply, its oxygen, its nutrients. Where does it get that from? It gets that from, obviously, from the aqueous humor. And aqueous humor doesn't just go into the layers. It has to diffuse, get what it needs, the supply that we need, for example, oxygen, nutrients, glucose, etc. This is done by the endothelium, because this cell layer is metabolically active. It regulates a cell, and between the cells and each other is the junction between them is the adherents, occludents, and desmosomes. This is lecture-wise, but I don't really think it should be asked in the OSPE. We're not really sure nowadays. Okay, now the last layer of the outer fibrous layer is the limbus, and the limbus is the junction between the cornea and the stroma. It is where the cornea ends and the sclera begins, or where the sclera ends and the cornea begins, whatever you'd like to say. Okay, so it is basically a transitional zone. So we said structurally the sclera and the cornea are very different, even though they are fibrous tissues. So sclera is irregularly arranged. Cornea is, subhanAllah, very organized in its arrangement of the fibers. At the limbus, the cornea, it gets less regular, and the sclera, it gets more like regular. So if you get what I mean. So limbus is the junction, it is a transitional zone. And the significance here is that we have the trabecular meshwork that comes together to form the canal of Schlemm. And this angle, because you know the eye has like angle kind of thing, this angle is the iridocorneal angle, and this is where we have the drainage of the aqueous humor. Obviously, any obstruction in the canal of Schlemm or any excess production of the aqueous humor will lead to increased intraocular pressure, what we call glaucoma. Okay, this is the histology of it, and this is the canal of Schlemm, this trabecular meshwork, and if this is aqueous fluid, this is my mouse, is aqueous fluid, it comes and gets drained here. And this area, entire thing, is the limbus. Okay, we are done from the first layer of the eye, which was the outer fibrous layer. Now to go into the middle vascular layer, another word for it is called the uvea. The uvea is made out of three main structures: the iris, the ciliary body, which is subdivided into the ciliary process, and the ciliary muscle, or the ciliary stroma, and the choroid. Okay, so let's see. Obviously, it is vascular for a reason, because the outer part is the outer part is avascular, and it needs nutrition from somewhere. This is the uvea function. Now, let's start with the iris. Iris is the colored part of the eye. If you have green eyes, this is your green iris. If you have brown eyes, this is your brown iris. Okay, so iris itself is it is a pigmented layer, so it has pigments, but mostly it is it's a muscle. Okay, I'd like to think about it this way. So it is not purely muscle, it has also other tissues, but it is mostly a muscle. It has contractile diaphragms, and it's smooth muscles, because the main function of the iris is to control the size of the pupil in accommodation reflex, either to constrict it, to focus the light to focus the light in near vision, or to dilate it to increase the amount of light entering through the pupil in far vision. Okay, so it has two muscles, obviously: the pupillary muscle, which is a short circular, the arrangement of the fibers itself is short and circular, so short circular constrictor muscle. It is under the control of the parasympathetic. The dilator pupillary muscle, it is long and radial sympathetic. Okay, how to remember it? You know, short for short vision, for near vision, short circular vision is short circular pupillary muscle. Okay, now long radial for long vision, long radial muscle for long vision, which is, you know, dilator pupillary muscle. Okay, again, it is highly pigmented layer. It has melanin. Melanin is basically the pigment, green, brown, I'm gonna say yellow, but there's no yellow eyes. Okay, anyways, it is highly vascular because it is part of the uvea, which is a highly vascularized epithelia. Okay, ciliary body. Now, ciliary body is made out of two main components. It is the ciliary stroma and the ciliary process. The epithelia of this ciliary body is a simple columnar epithelia, and it is double layered. So it's a double layered simple columnar epithelia. Okay. Now, the ciliary stroma, it is two main layers, the inner vascular and the outer muscular. And we know that we have ciliary muscles. Okay, ciliary muscles control the tension of the sphincter, the suspensory ligaments or the zonular fibers to control and adjust the size of the lens itself. Okay, so these are the outer muscular ciliary muscles. We actually have three of them. Two of them is what I just mentioned, which controls the size of the lens itself. It is the radial oblique for far vision and the circular sphincteric for near vision. Okay, the third layer of muscle is the meridional longitudinal muscle. So it is arranged in a longitudinal manner, and the function of this muscle is to stretch the choroid. When it stretches the choroid, it opens the iridocorneal angle. When it opens the angle, we increase the drainage of the aqueous humor. Okay, these are just the functions. So if we have a question, what are the layers of or what are the muscular layers in the ciliary body? We mentioned them in OSPE. Very direct, meridional longitudinal fibers, radial oblique fibers, and circular sphincteric muscle fibers. Okay, now, we have the ciliary process as well, part of the ciliary body. Ciliary process is the part of ciliary body that produces the aqueous humor. So to be more specific, ciliary body produces aqueous humor. We know that. But which part of the ciliary body? It is not the muscle, obviously. It is not the vascular part. These are blood vessels. These are only for nutritional supply. What produces the aqueous humor is the ciliary process. Okay, so produces aqueous humor. It is a part of the, excuse me, that's a typo here. Okay, it's part of the blood aqueous barrier, which is part of the blood ocular barrier. So it's just part of the barrier of the eye. Okay, and it is attachment. It is for the attachment and the anchoring of the zonular fibers. Let me come here. So this is a drawing, like a schematic diagram, obviously not histologically accurate, but this is like the ciliary body, entire thing. Okay, so let's see. This is the ciliary let's say, body. These are the ciliary processes, this pink thing, process. This is where this purple thin lines, these are the zonular fibers or the suspensory ligaments. And these are the muscles. So I said these are the circular sphincteric muscles. It comes obliquely, so it's like the oblique radial muscles. This is for near vision, this is for far vision, and this is the meridional longitudinal for the stretching of the choroid, and this red thing is mimicking a blood vessel because this is vascular layer. Okay, again, here, this is a ciliary body. This will be the ciliary processes. And obviously it's not mentioned because this is a low quality image, but if I extend here, this will be the zonular fibers or the suspensory ligaments. Again, this is the ciliary body, entire thing. And then these are the ciliary processes. If I extend here lines to attach to the lens, this is the lens, it will be the zonular fibers. Okay, so, and here is the iris, obviously. This is the canal of Schlemm at the iridocorneal angle. Okay, now the third layer of the uvea or the middle vascular layer is the choroid, which is a dark brown purple, and it is highly vascular. Okay, so let's see. This is the sclera, which is outer white part. Between the sclera and the inner retina is the choroid layer. Okay, so between the sclera and the retina is a choroid. Let's say there's the layers of the eye from the beginning. Okay, so we have let's say the bulbar conjugate, and then we have the episclera, and then we have the sclera, and between the sclera, after the sclera is the choroid. After the choroid, we have the retina. Okay, and then inside this part here is the vitreous body, but you know, later. Okay, choroid is dark brown, and sometimes it's purple, and it's highly vascular. It has the membrane that separates it from the retina is called the Bruch's membrane or the Bruch's membrane, however you like to call it. So if this is the choroid, this entire thing is a choroid, and upper here we have the retina. The separation line or membrane line is the Bruch's membrane. Okay. Okay, let's continue. Okay, this is again, this is here, this is a choroid, this is the Bruch's membrane. Here we have the 10 layers of the retina. Okay, now we have the lens. The lens is not part of the eye layers, but obviously it is an integral part of the eye because it controls the amount of light that comes in and goes. It is transparent. Again, it is transparent with the same concept like the cornea is transparent because of the arrangement of the fibers. It is avascular, again, blood. We don't want to see blood or like we don't want to see red things. We want to see clear things. That's why it's avascular. It is biconvex lens. So our lens is a biconvex lens. And in cases of myopia and hypermetropia or like refractory errors, we use different lenses like biconcave lens or a cylindrical lens in astigmatism, for example. Okay, again, it's extended by these zonular fibers. Here, this is the zonular fibers of the suspensory ligaments. Here is the lens. Here's the zonular fibers. Here is the lens. Okay, it has three main layers, which we're going to discuss. This is the outer part is the lens capsule, and then we have the subscapular or epithelial layer of the lens, and then the inner part is the actual lens fibers that refracts the light. So lens capsular, the lens capsule is a thick basal lamina. It's thick at the edges, and it has type 4 collagen. So it is a thick layer, like say a capsule is a protective layer, so it protects the lens kind of, and it is thickest at the edges where it is suspended from the suspensory ligaments. Okay, the subscapular layer of the lens, it has cells that are very mitotically active, and they are connected together by gap junctions, and the type cells are cuboidal cells. So see here, this is a cuboidal cell. Cuboidal cell is even labeled here. This thin pink line that's kind of fading away is the capsule, and then we have the lens fiber. Let's discuss it here. Okay, so again, this is the capsule, and then the subcapsular epithelium, and then we have the lens fibers. The lens fibers, interestingly, is the elongation or the contraction of the fibers of the subcapsular epithelium. Okay, so subcapsular epithelium, we said it is a cuboidal cells that are mitotically active, and they produce lots of collagen and nutrients that we need for the lens. These fibers, that comes from the subcapsular epithelia, extends down as the lens fibers. Okay, as they extend down, they lose their nuclei. So here we have a lot of nuclei, less nuclei here, even less nuclei here, no nuclei here. This is a mature lens fiber. So as we go down or deeper into the lens, the subcapsular epithelium will lose its organelles and become only fibers to form the lens fibers. Okay, the lens fiber, it is a fiber, but it also has a protein called crystalline protein. Crystalline protein, from the name, it's crystal, so it is, the function is to refract the light or aid in the refraction of the light. If we have excess deposition of this crystalline, the clinical significance here is a cataract, and another clinical significance, which is due to age, where we lose elasticity of the lens, because when you shape, it becomes more flat or it becomes more round, depending on the vision. When it loses this elasticity, it is a condition that we call presbyopia, but that's for pathology. Okay, now we are done from the lens, the middle and the outer layers of the eye. Now for the last thing in our histology section is the inner retina, which is the inner neural layer. This is a pretty image of the retina. We also have the choroid here, but we have the 10 layers of the retina that we're going to discuss. Basically, we have two main functional layers. So it's the pigmented layer and then the inner neural layer. Okay, and we have two parts of the retina: the visual part, which is the posterior part, and the non-visual part, which is the anterior part. They are separated by what we call the ora serrata, and then we have the another non-visual part is the physiological blind spot, which is where the optic disc is, where the optic canal exits, etc. Obviously, we're going to discuss the macula fovea centralis, and the 10 layers of the retina. So these are the 10 layers of the retina in order. They are a lot, but it is quite interestingly not very hard to memorize. So we have the pigmented layer. Okay, and then we have the photoreceptor layer, rods and cones, and then we have the outer limiting membrane, again, membrane limiting the separating layers or for structural support as well. And then here where it gets easier, we have outer nuclear, outer plexiform, inner nuclear, inner plexiform. So outer nuclear, outer plexiform, ONOPINIP. So just memorize it like that. And then we have the ganglionic cell layer, where we have the ganglionic cells that comes together to form the nerve fibrous layer. In between, we have the inner limiting membrane also for structural support. So this is another image. Here we have the choroid. Again, if you remember, the choroid is separated from the retina by which membrane? By the Brooks membrane or the Bruch's membrane, however you like to call it. We have the retinal pigmented layer, photoreceptor layer, which is the rods on the cones. Then you have the outer nuclear. It is out and it has nuclei, so outer nuclear. And then plexiform is where we have the synapses, because this layer said it's the inner neural layer. Neurons are synapses, so we have synapses happening here. So plexiform layers are the synapse. So here we have the synapse, outer plexiform, again, another nuclear layer. So it is the inner part because this is the outer one, this is the inner one, this is the synapse, another synapse, this is outer synapse. So this should be the inner synapse, so inner plexiform, because synapse is plexiform. And then ganglionic cell layer, they come together to form the fibrous layer, which comes together and be the optic nerve. Okay. Now, the retinal pigmented epithelium, which is this layer, has very significant functions. So one of let's start about the structure itself. The structure itself, again, is a single cuboidal cell. Okay, so mostly the shape of the cells in the eye is either simple cuboidal or squamous cells. Okay, so single cuboidal cell separated from the choroid by the Brooks membrane, and it is pigmented from the name retinal pigmented. So it is pigmented. It has a pigment. Functional significance of that is that we have light waves can go anywhere in any direction, and we don't want them to get reflected. Okay, I like to think about it, if we have a reflected light rays, we're going to shine light from our eyes, which is poetic, but we don't want that because that's a medical condition. But anyways, we want to absorb the light that is prone to get reflected, so we don't reflect it back and we don't have scatter, and we contribute to the clear vision. Okay, so this melanin will absorb the excess light to prevent the scatter and to prevent the reflection. Another function is for phagocytosis and regeneration, and it acts as part of the blood retinal barrier. Said the choroid is highly vascular, the retina is neural layer. We don't want blood to go here, to enter, right? So this layer, it acts like a barrier, the blood retinal barrier. Okay. I didn't add it in the slides because I didn't have time, but it is also for histology, as in theoretical histology. We have the rods and the cones, which are photoreceptor layer. The physiology of it is for phototransduction and the entire process of the of how the light waves are being transmitted or converted into electrical signals. Okay, now for the OSPE questions, which is the main part of this lecture. Let's see, name this part, or sorry, name this type of tissue. Where is it found, and list its layers. So let's go here. This should be the cornea. Okay, before I show you guys the answer, this should be the cornea. All of this tissue. This should be the epithelium. This should be in between the corneal epithelium. Next layer is the Bowman's layer or Bowman's membrane. And then after Bowman's membrane, we have the stroma. So this is the corneal epithelia, this is the Bowman's membrane, and this should be the corneal stroma. Okay, so this layer that the question is pointing at is the corneal epithelial layer. Okay, where is it found? Obviously in the cornea. The cornea is part of which layer of the eye? The outer fibrous layer of the eye. And list its layers. We said that the cornea has 5 sublayers: the squamous cell layer, then the polygonal cell layer, and the basilar cell layer. The basilar cell layer will then continue as, or like, is a continuation of the Bowman's membrane. Okay, now name the structure marked. Okay, so, and state 2 characteristics in which eye layer is located. So, I mean, this is not a very good question to put in the exam because you can see the answer here, which is ciliary body. So this is the ciliary body. Okay, the ciliary body is made out of the stroma and the ciliary processes. 2 characteristic is that it has cellular processes which produce aqueous humor. And which layer of the eye is this located? This is the ciliary body, part of the vascular layer, the middle vascular layer of the eye, or the uvea of the eye. Okay, another characteristic is that the ciliary body would have the ciliary muscles, and that's it. Okay, name the structure marked. The structure is marked. Number 3, originated from which structure? State a clinical significance. Okay, looking at the slide, I can say that this is what? This is the lens. Okay, so this opaque fading layer is the lens capsule. So number 1 is the lens capsule. Number 2 is directly beneath the lens capsule, so it should be the subcapsular epithelium, or yeah, the subcapsular epithelium. And then we have the lens fibers. So number 3, which is the lens fibers, originated from a structure, originated from the elongation and contraction of the subcapsular layer, or layer number 2. State a clinical significance. Can say anything, cataracts, for example. Okay, name the structure marked. Okay, this red thing, entire thing, is the iridocorneal angle. Where is it located? It is located at the limbus of the eye, between, or the junction between the cornea and the lenses. Sorry, excuse me. The sclera and the cornea. And the clinical significance of the structure is that if it's closed, like in closed angle glaucoma, it will lead to glaucoma or increased intraocular pressure. Okay, name the pathology shown. Okay, this is obviously retinal detachment. I didn't talk about it in details, but I said the normal tissue layers. So this is the choroid, this is the sclera, this is the choroid, and there should be the retina attached. So like here, it's a normal tissue. Here it is detached. So this is retinal detachment. It is between which layers retinal detachment usually happens or occurs, between the pigmented retinal layer and the neural retinal layer. Okay, which membrane of the cornea can regenerate? Is it located? Where is it located? Okay, so we said, or we mentioned, that we have 2 membranes in the cornea, which is the Descemet's membrane and the Bowman's membrane. Both of them are acellular, and both of them are for structural integrity and protection of the cornea. But one of them, the difference between them, other than the fact that if they are in different locations, is that the Descemet's is regenerative, the Bowman's is not. Okay, so Descemet's can regenerate, the Bowman's is not. The location of the Descemet's is between the corneal stroma and the endothelial layer, corneal endothelial layer, and the location of the Bowman's is between the corneal epithelia and the stroma. Okay, so this is just the answer. This is pointing at the correct choice. Okay, alhamdulillah, we are done from histology. Now let's go to microbiology. Microbiology, these are the organisms that we are going to discuss, that are also mentioned in the lecture. We have 3 microbiology lectures: oral cavity, the sinus, and the ear, and the eye. Okay, so oral cavity is going to be our first lecture. So Espiogenous is going to talk about it, its diseases, the morphology, the lab tests, and the cultures. Also included the lab, the microbiology lab, things that we just took in the microbiology lab. Okay, so the diseases that they cause Espiogenous is a pyogenic infection for the the oral cavity. It causes pharyngitis. It's systemic. If it is very acute and it went to systemic, it causes rheumatic fever and glomerulonephritis. I only mentioned this here, not for the case of completion, but because we took it in lab for tests like anti-streptolysin O and the rapid antigen test, which we're going to discuss later. But okay, the pharyngitis, it is the pathology shown. This is pharyngitis. So it is red swollen pharynx. We have red, so it's hyperemic and it is swollen. And it has purulent exudates. It is a bacteria from the name pyogenes pus. So pus or purulent exudates, and it should be inflamed. If it went to the tonsils, it can cause a lymphadenopathy, and it is the pharyngitis. It is caused by the pyogenic strains of Espiogenous. Okay, because it is pyogenous, but we have pyogenic and non-pyogenic strains. Okay, so this is an image of pharyngitis. Okay, how do we tell it? This should be red. I am very sorry about that, but it's red. It is swollen. It has purulent exudates, and it has inflamed tonsils. And yeah, that's pharyngitis. Okay, now the morphology of Espiogenous is that it is a gram-positive, so because it is purple. It is a cocci because the name of Streptococcus pyogenes, so cocci, and it is strept, so it is in chains, It can also be a diplococci. In some cases, like here, it's a diplococci, but mainly it is in chains because it's a strep. It is beta hemolytic. So in blood agar, it will show beta hemolysis, and it is a group A strep because of the vasopressin sensitivity, and it is pyogenic. It has pyogenic and non-pyogenic strains. So let's see what does group A strep mean. It is vasopressin sensitive. If you are vasopressin sensitive, that is group A. If it is not sensitive, then it's going to be agalactia. Okay, so this shows the pattern of beta hemolysis. And this is the bacitracin sensitivity test. If you have like a empty space around it, then it is sensitive. No bacterial growth here. That means it is sensitive. So this should be aspergillus. Here there is no growth around. There is growth around the bacitracin pill. That's why this is not pyogenes. It is agalactia. Okay, so it has streptolysin O is an antigen on the aspergillus. When we develop antibodies against streptolysin O, it's going to be anti-streptolysin O. Okay, this is one way to check for previous infection of aspergillus. And then we have the RAT, or the rapid antigen test. It is also called the rapid agglutination test. So next slides, don't worry. Okay, so the rapid antigen test, it is basically testing for the presence of group A straps. Okay, and we are testing from the name, we are testing for the antigen. So a patient is suspected of pharyngitis. We want to take a swab from the patient, a throat swab from the patient, and this throat swab, which has the bacteria has the antigen. So we're testing for the antigen. Okay, the procedure is basically we are adding the sample to a reagent with known antibodies that will bind to this antigen, and we are going to look for the binding. Okay, so we have the we have the kit. This is the specimen we collected, the throat swab. We have the kit, or the rapid antigen test kit, has two reagents, the A reagent and the B reagent. We shouldn't know the contents. It's basically antibodies, and one of them was called the gold sheep antibody, something like that. But we have antibodies we know that these antibodies should bind to what we know as the antigen of aspergillus. Okay, we put these drops, 3 drops here, 3 drops here. I know in the diagram it says 4, but in the lab, at least my TA said it is 3 drops of each reagent, 3 drops of A and then 3 drops of B. And then we get the throat swab and then return it, and then we squeeze it to make sure that we got everything. And then we put it in the kit. This is the place where we put the kit. Now we have controls. In any of the tests that we're going to mention, we have controls. A positive control, and then a negative control to make sure that the test is valid. If there is no control in the rapid antigen test, that means that the kit itself is dysfunctional, and we discard the investigations. Okay, then here we added the sample with the agents and with the throat swab sample, and then we wait for the test to occur. Then we look for the control line should be present. Okay, see, this test is invalid because we don't have a control line, even though when we added the sample, we showed we have a line here, but we discard this sample because we don't have a control. So we always look for a control. If you have a control, this test is valid, and then we look for the test itself, whether we have the sample bound to it or not. Here it is a negative test. That means that the patient doesn't have the antigen. Does that mean that the patient does not have pharyngitis? That is not true, because the rapid antigen test, it is, let me go here, excuse me. Okay, it is not it is specific, but it is not sensitive. Okay, so what we do culture after that. If we have a negative test, but the history of the patient is suspecting of pharyngitis, but it showed a negative test in the rapid antigen test, we don't discard the result and say, oh, this patient doesn't have pharyngitis. No, we do culturing to confirm. Okay, so it is yeah. That's the rapid antigen test. Next test is the anti-streptolysin O test, and we have two things here. We have the latex agglutination test, and we know latex, which is from POD and also from neuro, where if we have latex, if we have agglutination, that is a positive test. If we don't have agglutination, that is a negative test. And the second test, which is slightly new, is the neutralization test. Okay, both of them are testing for anti-streptolysin O. So again, streptolysin O is an antigen on aspergillus. When we have an infection, we are exposed of aspergillus, we produce the antibodies against it. Okay, so if we have high antibodies in the serum, it is indicative of previous or retrograde aspergillus infection. It is not new, because if you have an acute infection of bacteria, you still didn't develop the antibodies for it. So the anti-streptolysin O is for previous infection. So a patient comes in with rheumatic fever, and you want to know if this rheumatic fever is because of aspergillus. You do the latex agglutination test or the neutralization test. So latex agglutination, this is not for group A strep. This is just a random picture, but same concept. You have the antigen antibodies combining with the latex, and they form the agglutination. This is a positive result, and this is a negative result. Obviously, you should have a control as well. Now, for the new part, which is the neutralization test. In neutralization, another better name, in my opinion, for it is the dilution test, because we are taking the sample and we are diluting it. We are taking the sample from the patient's serum, so the blood, which should have antibodies, and we are putting it with a known concentration of the antigen that should bind. So the streptolysin O antigen will bind to the anti-streptolysin O antibodies from the patient's serum, and we keep on diluting until we don't see any agglutination. Okay, so we keep diluting, and if we have a positive, dilution in chemistry, it's titration, so we call this a titer. If a positive result, that means that you have more than 200 titers, and a negative result if you have less than 200. Okay, so again, let's see. This is the controls based on the concentration. So I added the sample here, and I keep diluting, I keep diluting, I keep diluting. And the titer is basically the last circle, if you will, or the last bit where we have a positive result. Okay, so in A, this is 3, this is the titer. And in B, this is 7, this is the last one. Okay, in E, this is D10. Okay. Okay, again, this is another picture. Again, you have the serum, and then you keep on diluting, keep on diluting, keep on diluting, till you stop having a positive result. Okay, once you stop having the positive result, the next step is you have a negative result. This should be the titer. Okay, so if I have a positive here, and then I have a negative here, the titer should be 1 out of 257, which is basically just the concentration or the titer. Okay, now we have something called the prozone effect. And the prozone effect is when the patient has a very, very high amount or concentration of the antibodies in his serum. Okay, it is like when you have a lot of sugar in a cup of water, and you see sedimentation of the sugar because there's not enough water particles to bind to the sugar and dissolve it. That's why we have sedimentation. It is the same concept here. We have a lot of antibodies in the serum that the known concentration of the antigen in our dish or in our sample is not enough to bind to it and show a positive result. Okay, so here is negative. It's a known negative, so there is no like binding. Okay, this is a known positive, so we have binding in all of the titers or in all of the concentrations. But in the prozone effect, you have a negative result here, but a positive result here, positive result here. Okay, so what do you do in this case? What do you do in this case is that you either dilute till you stop having a positive result. And then you know that this is because you have high amount of antibodies in the serum, or like very excessive high amount of antibodies. Okay. Alhamdulillah, we are done from aspergillus, we are done from the rapid antigen test, anti-streptolysin O, which included the latex and the neutralization test. Now let's go to C. diphtheria. Or Corynebacterium diphtheria. It causes diphtheria pharyngitis, and systemically it can lead to endocarditis. This is the picture of diphtheria, and it could be misleading because you think this is a spore, but it is it's a metachromatic granule. We're going to discuss it now, but let's see diphtheria first. Diphtheria, it is a postnasal exudate, and the very we fear obstruction. This is the important thing. Diphtheria is very severe, even though now it's not common because alhamdulillah we have the vaccine, but it is very severe because it can lead to direct obstruction of the airway, and also we have the necrotic tissue. What causes the diphtheria? It is the AB toxin of the Corynebacterium diphtheria, which is an exotoxin, of course. So let's talk about the morphology first. It is a gram-positive because it's purple, and it's in rods because that's a bacilli. Okay, it is not spore forming. I should delete that, sorry, but it is not spore forming. This thing is a metachromatic granule on methylene blue stain. Okay, and it has 4 known biotypes, and the biotypes that we should know, it's a mitis biotype because it is the one that causes the diphtheria in humans. Okay, now we said that the diphtheria itself, the disease itself, is caused by the exotoxin, which is an AB toxin from a lysogenic bacteriophage. So it got it from a virus. The main function of this, or like how does this toxin cause the disease, is by inhibiting protein synthesis. Okay, so we have the A subunit, which is the active site, the B subunit, which is a binding site, so it binds to the cell, and then we have, it's not here, but it's the R subunit, which is the receptor binding site. Which receptor does it bind to? It binds to the heparin binding epidermal growth factor receptor, a receptor on the red blood cells. When it enters, it stimulates a cascade that goes and then it goes and binds to elongation factor 2, which is a protein that aids in the translation process, or like the elongation process of translation in protein synthesis. So it goes and inhibits protein, it inhibits the entire process of protein synthesis, you have cell death. So overview. Again, this is the AB toxin in picture. AB toxin comes, binds to the heparin binding growth factor on red blood cells, enters, goes to the E2, or like elongation factor 2, and inhibits protein synthesis. Okay, the lab test, which is very important in important for Corynebacterium diphtheria, is the LX test. Okay, we can also do serology like PCR and NATs. Excuse me. We can do culturing, and these are some of the cultures that we can use. I'm going to go through that for later. For OSPE's sake, it's the LX test, and the LX test is the gold standard for C. diphtheria. Okay, so we have a filter paper. Let me go here. We have a filter paper with a known antitoxin. Okay, so we have an antitoxin that is filling this filter paper, and then we have a positive and a negative control. A positive control is that a known toxigenic strain of C. diphtheria. Okay, so a positive control is the known toxogenic strand of C. diphtheria. The negative control is the unknown toxogenic strand of the C. diphtheria. Okay, so a positive control will be the known toxogenic strand. The negative control will be the known non-toxogenic strand, and then we have the swab from the patient. Okay, the swab from the patient with C. diphtheria, he has C. diphtheria, so he should have the toxin. The toxin should bind to the antitoxin, and it shows a perceptin line. So the LX test, again, if the positive test for LX test is you have a perceptin line, a negative test is you don't have a perceptin line, and that indicates that the strain or the biotype of the bacteria is non-toxigenic. So again, this is a perceptin line. That means that this strain is toxigenic. You don't have a line here. For example, this is a non-toxigenic strand. Okay. Now let's go to Vincent's angina. I like to remember him by Vincent van Gogh. But anyways, another name is acute necrotizing gingivitis and trenched mouth. We have this sign, 3 things: swollen gums, a lot of bleeding, a lot of ulcers, and halitosis. So this is the image for Vincent's angina. Okay. It is caused by it's polymicrobial, but it can be caused by bactericides like gram-negative bacteria, but also spirochetes like Treponema and Borrelia. Okay, so this is a polymicrobial slide with a patient with these symptoms like halitosis, ulcers, bleeding gums, and you are suspected of Vincent's angina. You do a gram stain, and you look at it under the microscope, you see a polymicrobial culture. Okay, so this here is a spirochete, this is another spirochete, this is a spirochete, and here this is a gram-positive, like a diplococci. It could be anything, actually. Okay, the other type of angina is the Ludwig's angina. Ludwig Beethoven is this guy, so that's why I remember it this way. This is the image of Ludwig's angina. And I know this is like in the lecture, but they might ask us in the OSPE, so I'm sorry, please bear with me. But it is caused by these things. And the important thing here is the Brony heart sign. So Brony heart sign is this patient with a very swollen chin with elevated tongue, and it is also protruded tongue. And this chin, we call it the Brownie neck. And if the patient, if you palpated the submandibular gland, this submandibular gland, it will be tender and it will be enlarged. Okay, again, both of the angina, like the Ludwig's and the Vincent's, are polymicrobial. So in under the microscope, you can see a lot of different species of bacteria. Okay, now let's go to fungal, which is the candiasis. We have only one species, which is Candida albicans. Alhamdulillah, we don't need to know the morphology or what is the yeast form, what is the pseudohypha form, or whatever. We only need to know what is pseudomembranous candidiasis and erythematous candidiasis. Okay, we already know that candidiasis, or like any fungal infection, is opportunistic, so it will affect the extremes of age, the immunocompromised, and diabetic patients. Okay, so this is pseudomembranous candidiasis. You have a pseudomembrane in the soft tissues in the oral cavity. What are the soft tissues? You have the tongue, you have the soft palate, you have the gingiva, you have the pharynx. Okay, so creamy white plaques or pseudomembranes. Okay, these pseudomembranes, when they are removed or when they are scraped off, they will bleed. There will be a lot of bleeding. Okay, so yeah, that's the sign here. Okay, so this is erythematous candidiasis, and it is from a recurrent state of pseudomembrane. The pseudomembranous candidiasis. Okay, so I'd like to think about it's like the chronic form of it or the recurrent form of it. You're always getting these white plaques, and then suddenly the body is got like you are in a chronic state of inflammation, and then you have this appearance. I'm not talking about you personally, you're like for the sake of discussion. Okay, so what do we see? It is at the base of the tongue or the dorsum of the tongue. We have a lot of deep papilla, which we call depapillation. It is very red from the name erythematous, so erythemia and redness, and depapillation, deep papilla, and a lot of papilla of the tongue. So it is hyperplasia of the tongue as well. So three things: hyperplasia, erythematous areas, and depapillation or deep papilla. Okay, we are done from fungal, bacterial, from oral cavity. Now let's go to viral. We have EBV, mumps, and measles. Okay, so EBV, we have the complications of EBV. This is just, the mnemonic, how to remember them. You can read it if you want, but in 4-lab, we have the infectious mononucleosis. So infectious mononucleosis will present or will have same presentation as group A strep or like pharyngitis. So asparaginus and EBV will have, or like EBV, infectious mononucleosis specifically, will have the same symptoms. Okay, so it will mimic a strep throat. Okay, how to differentiate? So a patient comes in and he is suspected of pharyngitis, but you don't know if it's pharyngitis or infectious mononucleosis. What you do is that the monospot test. The monospot test, it is for EBV. If it's positive, then this the infectious agent is EBV. Okay, so what is the monospot test? Okay, so EBV virus will invade the pharynx cells and it will also invade the B cells. When it invades the B cells, it will cause what we call the heterophilic IgM antibodies. Okay, so the monospot test will have, let's say, an antigen that will bind to this heterophilic antibodies. And if it is positive, if there is binding, then it is EBV. If there is no binding, there is no IgM antibodies, and it is group A strep, if it is in fact a case of pharyngitis. Okay, so this is just to differentiate between infectious mononucleosis from EBV and strep throat from asparaginus by the monospot test. Okay, now we have the measles and mumps. I just added here, it will cause parotitis and orchitis, but we don't have any picture in mumps, just the pathology that it causes, but we do have in measles. Measles and mumps are both paramoxyviruses, and measles, it has it shows this appearance, which we call the Kuplik spot. So these white spots, small things, dots like pimples kind of thing, is called a Kuplik spot for measles. I like to remember it. Qubla is like kiss in Arabic, so Kuplik spot measles. So if you kiss someone, you'll get measles. Qubla, you will get measles. Okay, just a mnemonic. Okay, we are done, alhamdulillah, from the first microbiology lectures with the disease, with the organisms that we should mention. Next is the ear lecture or the sinuses lecture, where we have otitis media, sinusitis, the pathophysiology. Obviously, you should read it on your own. It's not in this OSPE, okay? It's like other microbiology questions. Okay, these are the organisms we're going to discuss. So we have acute otitis media and we have chronic otitis media. The acute otitis media is going to be by these three: S. pneumo, H. influenza, and Moraxella. If you have chronic, chronic otitis media, it's going to be by S. aureus and Pseudomonas aeruginosa. So each organism one by one. So S. pneumonia. Here we will not talk about the disease because all of them will cause otitis media. So disease is not really significant here. So we're only going to discuss the morphology and the virulence factors. So S. pneumonia, it is a gram-positive. Here, it is a gram-positive. It is a cocci, and it is in chains, and sometimes it can be a diplococci. So it can be in chains because it's a strep, and it can also be in diplococci, like in this case. Okay, it is catalase negative and it is lysed by bile. It is alpha hemolytic and it is optochain sensitive. It is encapsulated and it is fastidious. Okay, so it is encapsulated is one of the virulence factors. So it is encapsulated by a polysaccharide capsule, and any capsule is like a protection from what? From phagocytosis. Okay, it has an adhesion protein to stick to the mucosal surfaces, and it has the endotoxin pneumolysin, which inhibits again phagocytosis, and it increases the complement and inflammation. Here is the image showing how the it is optochain sensitive. Okay. Now let's go to H. influenza. H. influenza or Haemophilus influenza, it is it depends on the strain actually. So the non-capsulated strain, okay, will cause otitis media and the sinusitis. The capsulated strains like influenza B, H. influenza B will cause meningitis. Okay, so this image is, you know, it is of H. influenza, but this obviously has a capsule, this has a capsule. It will not cause otitis media. It will cause cases like meningitis. Okay, so only the non-capsulated strains of H. influenza will cause otitis media and sinusitis. Type. The morphology is that it is gram-negative because it is pink, or like gram-negative, it didn't retain the gram stain, and it is a coccobacilli. It can be in rods, it can be in a cocci. It is a facultative anaerobe. It is oxidase positive, and it is fastidious, which is also important to note because of the satellism test. It is fastidious, that means that it needs specific requirements for it to grow. That what is it other than the fact that it needs carbon dioxide? It needs the Heman factor and the NAD factor, or factor 5 and factor 5 and factor 10 respectively. Okay, it can grow on chocolate agar, and yeah, and also blood agar, obviously. Here it's the chocolate agar, and this is presumably H. influenza, but it could be anything really. Okay, virulence for the H. influenza is 3. Again, if it is it can have a capsule, it cannot have a capsule. So if it has a capsule, it will not cause otitis media, but the capsulated strains, which causes meningitis, this capsule will protect it from phagocytosis. It has a pili, so it can move, and it also can adhere to the mucosal surfaces. It has IgA protease, so it inhibits the immune system by breaking down the IgA antibody. Okay, so 3 things, straightforward, alhamdulillah. Okay, now the satellism test is a way to diagnose H. influenza. It was repeated in neuro, it came in POD, it came here again. So satellism test is like, we should know it by heart. It's a streak of S. aureus. S. aureus will provide H. influenza with the factors that it needs, which is the Heman factor and the NAD. It allows the H. influenza to grow, satellism phenomena. Okay. Now the third organism that causes acute, acute otitis media is Moraxella catarrhalis. It is very age dependent. So if we have a patient with, or an adult patient with otitis media, Moraxella catarrhalis is not really suspected because it is only affecting children. Okay, so again, this is Moraxella catarrhalis, and it looks like what it looks like Neisseria. The morphology is very similar to Neisseria, but obviously these are different species, so they have a difference. Where is the difference? We're going to discuss. So it's a gram-negative, it's a diplococci, and it looks like Neisseria in shape. It is catalase positive, it is oxidase positive, it is DNase positive, it can grow on blood and chocolate agar. So it's similar to Neisseria in most of the things except for DNase positive. Okay, so let's go here first. Moraxella versus Neisseria. Moraxella is DNase positive, Neisseria is, again, a typo, my mistake, my apologies. Neisseria is DNase negative. Okay, so you have two culture specimens. Both of them look the same under gram stain, and you forgot which patient had. One patient had meningitis, and the culture was for Neisseria. One patient had otitis media, and the organism was Moraxella, but you mix them up. You don't know which agar is for which patient. Which test do you do? It's the DNase test. If you have agglutination, or if you have a positive test, then it's Moraxella. If you have a negative test, then it's Neisseria. Okay. Let's go back here. This is the virulence for Moraxella. It has adhesion protein to, again, adhere to the mucosa. So as you can notice, there is a pattern of something, of virulence factors, where the three organisms that we discussed have something that makes them stick to the mucosal surfaces. Okay, it also has a biofilm. A biofilm is also like a capsule that it also inhibits phagocytosis. So common virulence factors is something to inhibit phagocytosis and something to make you stick to something. Okay. Now, for the organisms that causes the chronic otitis media, we said we have two: the S. aureus, Staph aureus, and the Pseudomonas aeruginosa. Okay. This is Staph aureus in a 3D diagram. I don't think it's like accurate, but just, design. Morphology for Staph aureus is, again, I'm really sick of like explaining Staph aureus for myself again and again. 3 blocks in a row now. Okay, so gram-positive cocci in clusters, which is catalase positive, which is coagulase positive. It is DNase positive, and it grows in blood agar. It also can show like beta hemolysis and stuff. Virulence is like, it's an exotoxin. It has protein A. It has enzymes that are called invasins. So it, from the name, it invades. It invades what? It invades cellular stromas like hyaluronidases, leukocidins, and kinases. This is the catalase test. So obviously this is Staph aureus. This is not Staph aureus, or this is streptococci actually. Okay. This is Staph on blood agar, but it can go multiple agars again. So Pseudomembranous aeruginosa is our last organism in the second lecture, which is again involved in chronic otitis media, excuse me. And the thing that I noticed in the lecture, that all of them will affect the immunocompromised, because you have to have the immune system affected in one way or another, so a suppressed immune system. But for Pseudomonas aeruginosa, the doctor said that it is also affecting cystic fibrosis patient, and I think that's significant. Maybe she will ask about it, but a cystic fibrosis patient with cystic fibrosis have high chances of conducting or getting a pseudomembranous aeruginosa and manifesting as chronic otitis media. Okay. Now, the gram stain for Pseudomonas, it could be really like mistaken for Haemophilus, for example. But what we do specifically is like, the culture, not the gram stain, but nonetheless, it is gram negative. It is non-spore forming bacilli, and it is aerobic, it is oxidase positive and catalase positive, and it forms the diffusible pigments, which we know the Pseudomonas is the beautiful bacteria which is doing the pigments. Okay, so we have the pyochinin and the pyruvin, and I think this was called also the fluorocidin or something like that, but blue, red, and yellow pigments. Just the fancy words for pigments, just saying pigments. Okay, the virulence, this is Pseudomonas on the agar, and it is green because it has, or like the strain that has the green pigment. So the pili, or like the pyochinin pigment. So the pili, it has pili, it has flagella, that's why it moves, and it has exotoxins, it has phospholipases, it has elastases, alkaline phosphatases. Again, these are enzymes that makes it invade the nearby structures. Okay, so it has a flagella, so it moves. It has something to adhere to the mucosa, and it has something to invade the mucosa. Okay, so yeah, we are done from the second microbiology lecture. Now for the eye. Let's see. The eye is very straightforward, and alhamdulillah, we only have minor like causes or like microbes. So we have conjunctivitis. Conjunctivitis, it can be microbial like bacterial and viral, non-microbial like allergic or reactive, and it can be chlamydia conjunctivitis. For some reason, even though chlamydia is bacteria, it is criteria on its own. Okay, so the three differentials here is that viral is we have increased lacrimation. This is viral conjunctivitis. In bacteria, you have mucopurulent discharge, and in a specific virus, which we call the Coxsackie virus, we have a hemorrhage. So in Coxsackie, we have hemorrhage. In any bacteria, we have mucopurulent discharge. In virus, generally, we have increased lacrimation and also obviously redness. Okay. So this is acute hemorrhagic conjunctivitis. This is a picture of it, and it is made or like it is caused by the virus Coxsackie A24 virus. And I like to remember it looks like an enemy eye. Okay, so an enemy eye, and Sackie is a very enemy name. So enemy eyes is by Sackie, or enemy eyes of Sackie is acute, so acute hemorrhagic conjunctivitis. Okay, this is inclusion conjunctivitis, which is by the Chlamydia trachomatis species. So chlamydia, it has serotypes or like biotypes. We have the types A, C, which we're going to discuss in trachoma. We also have the chlamydia types D and K, and D and K types are going to produce inclusion conjunctivitis. Okay. If I look at that, I'm just going to say that's conjunctivitis, but in the lecture, they said that this is inclusion conjunctivitis. Okay, so the disease is characterized by its onset, okay? And it could be really mistaken for Neisseria gonorrhea congenital conjunctivitis, or sorry, not congenital, neonatal conjunctivitis. Okay, so the disease onset is very important to differentiate between gonorrhea, Neisseria gonorrhea, and chlamydia D and types D to K. Okay, so chlamydia D to K will have the onset of 2 to 25 days, while Neisseria, it's more acute than this chlamydia, and it is 1 to 2 days after birth. Okay, so if a baby who just got birth has inclusion or like has conjunctivitis 13 days after birth, it will not be Neisseria gonorrhea, because Neisseria gonorrhea will manifest 1 to 2 days. It's going to be chlamydia. Okay, now for trachoma, which is the primary cause or the first cause of blindness, and the second cause of blindness is going to be, as we're going to discuss later, is by onchocerca or river blindness. Okay, so trachoma is by the chlamydia types A, B, A, and C. So A to C types. So D to K is going to inclusion conjunctivitis. A to C is going to produce trachoma. And trachoma is, we have like different presentations, and it depends on the severity. So in the beginning, you have like insult to the conjunctiva, where you're going to have the cobblestone appearance. And then you're going to be having the erosion or like the scarring of the corneal scarring, and also the conjunctival scarring. And then you have the corneal opacity, which is a very late stage. Okay, so first is a cobblestone appearance, which is basically just an insult to the conjunctiva, and then the scarring and the recurrent infection is going to have scarring to the cornea and also to the conjunctiva. If it goes to the cornea, it could lead to corneal opacity. Type. Now for the chlamydia itself, we have two forms of this bacteria. We have the infective elementary body and the reticulate body. The chlamydia is an obligate intracellular, so it will not live outside of the cell. If it enters the cell, if the infective form enters the cell, it will cause an infection. So to look or diagnose chlamydia, we do the Giemsia stain. So not the gram stain, this is a Giemsia stain, and we look for a very important thing. So the infective form is elementary body. What do we look for inside the cell? We look for the elementary body. So will be inside the cytoplasm, so intracytoplasmic, elementary body, and it's in inclusion, so it's an inclusion. So Giemsia stain for chlamydia, we look for intracytoplasmic elementary bodies. Okay. Now, for the stye eyelid infection, it could be because of an infective form like S. aureus or hordeolum. hordeolum will cause S. aureus will cause hordeolum, which is an infective form of eyelid infection or stye, and non-infection causes of stye is called chalazion or cyst, I think. Yeah. Okay. Now the last one is the Onchocerca volvulus, and it is this worm, and the worm is transmitted by the Simulium damnosum, or a black fly. So this is a species called Simulium damnosum, or just a black fly. The Onchocerca, it's called onchocerciasis or river blindness. It manifests in the eye, but it can also have like skin manifestations as well, or cutaneous manifestations. The area differs geographically. This is all of them in the lecture, but in OSPE they could ask us what is the infective form of this. Okay, we're going to say it is the L3 larva form. Okay, we should know the life cycle, obviously, but the infective form is the L3 larva. So when this black fly comes for a blood meal, it will inject this L3 larva inside of us. Okay. So to diagnose it, there's a test called the skin snap test, and we should take some of the epidermis of the skin, not the entire dermis, and there should not be any bleeding. If there's bleeding, then this is a biopsy. So it is a skin snap test. It is a golden standard for Onchocerca volvulus, and this is appearance of, the worm inside of the eye, which is, pretty disgusting. You're done. Jama'a, alhamdulillah. Congratulations. Now for the OSPE, it's going to be quick, I promise. Okay, so name this organism, less two if it's virulence factor, and name significant test for this organism. So this is what? This is H. influenza or Haemophilus influenza. Two of the virulence factor is the IgA protease. It has also a pili. And the name a significant test is the satalism test positive with S. aureus, or like any bacteria that provides the hemin factor and the NAD for Haemophilus, but we only took S. aureus, so it's S. aureus. What is the most common, I think that is a mistake while me editing, excuse me. Which of the following leads to otitis media in patients with cystic fibrosis? Okay, that's why I added this lecture, this question. Cystic fibrosis is Pseudomonas. Pseudomonas will affect patients with cystic fibrosis. Okay. What is this picture show? Say the organism causing it. Again, this is anemia eyes of Saki. So Coxsackie virus will cause acute hemorrhagic conjunctivitis. Okay, name this test. If it's positive, then what's going to happen? This is the LX test. If it is positive, then it is positive for the toxogenic strains of Corneobacterium diphtheria. So be specific, because LX test is for Corneobacterium diphtheria. Okay, it's not for any other bacteria. But what we do it for is we do it for testing for the toxogenic versus the non-toxogenic strain. Okay, so it's very important to mention that it is for the toxogenic strains for C. diphtheria. Now, what is this test? This is the skin snap test. It tests for Onchocerca volvulus, which causes what? River blindness. Okay. Which type of chlamydia species is this? Okay, and the pathology shown. So what is this? This is corneal, not corneal, excuse me. This is, the scarring of the lid, and this is because of a trachoma case by chlamydia. Which type of chlamydia causes the trachoma is A to C. Okay, D to K will cause the inclusion conjunctivitis in neonates between 2 to 25 days. Okay. Type, this is a stye, and this is a cobblestone appearance in a trachoma. Okay. Type. Now for the lab tests that we just took in the microbiology lab. An anti-streptolysin O titer was performed for a child with rheumatic fever. What is the amount? Okay, so remember, as I said, when we stop having the positives, once we stop having the positive and we have the negatives, the last one will be what? The last one will be our titer. So here we have a positive control, here we have a negative control, and here we have the titers. Obviously, this is one test, this is the other test. Okay, so I just want you guys to tell me which, here what is the titer, here what is the titer, here it is 200, here it is 600. Okay. I should change that, excuse me. I just took it from 14th batch. Okay. No, I'm very sorry, excuse me. This is the first thing. Okay. you take the last tube that shows a positive reaction. Okay. Type, what is the sign and name of the causative agent? Okay, this is the white spots of Kuplex, Kubla of measles, so Kuplex sign of measles. Okay. Okay, 2 days before a baby was born, a purulent discharge was noticed, and the second-year medical student suspected neonatal conjunctivitis but wants to confirm the causative agent. What must she do to know which organism caused it? So, 2 days after the baby was born. So this is confusing here because we said 1 to 2 will be Neisseria gonorrhea, but 2 to 25 will be chlamydia types D2K. So it's exactly 2 days. Now what? Now what? We are going to do we're going to take a swab from the patient. We're going to do cultures, and specifically, we're going to do this GIMCS stain to look for the intracytoplasmic inclusions of inside the cell. Okay, so this is the answer. This is ELIX test for toxigenic strains of bacteria, and this is Optotrin test for Optotrin sensitivity. Okay, طيب, a patient came in with congested throat, white pseudomonas tonsillitis, and the second-year medical student who just finished her HNS exam suspected 2 organisms, but wants to conduct tests to confirm if it's viral or bacterial. Okay, so if it's viral or bacterial, what we are testing for, it's either EBV, infectious mononucleosis, or a strep throat from group A strep. We do a monospot test. If it is positive, then it is positive for IgM antibodies for EBV, infectious mononucleosis. Okay, alhamdulillah, we are done from this lecture. Please scan the code. I hope that I included everything. Best of luck on your exam, guys, and please pray for me and pray for yourself, obviously. Thank you so much. And these are the free stickers from the template that I used. So I'm going to stop sharing. I'm going to stop recording and have a good night.